Okay, I'll go back to this. I'm actually glad to see at least some people in person here. I believe you checked in the Zoom people can hear us, right? Yeah. Okay, perfect. I'm gonna move this out of here so that it doesn't appear there. Okay. Oh, perfect. I got a thumbs up on Zoom as well. Okay. So like Michael mentioned, we're going to be kind of tag teaming today. So he can introduce himself, but he is one of our education directors at Ames, and he's also an MS1. For those of you who are not in medicine, we like using a lot of abbreviations. MS1 just means medical student year one. And you probably know me by now. I hope you do. Are we on video on Zoom? I don't think we are. There we go. I think now we should be. Okay, perfect. Now people on Zoom can also see me. Okay, perfect. Okay, anyways. Okay. And I'm an MD PhD 4, meaning I've done 2 years of med school and 2 years of PhD. That's just another I guess braggy way of saying what we do. Okay, so as Michael mentioned, we're going to be doing radiology, pathology, and cardiology. So there's a bunch of specialties today that's going to be presented here. So I'm going to try and get through these real quick. Like I said, we're going to be tag teaming this. And by that, I mean, I'm here for emotional support and Michael's going to do the bulk of the work. And with that, let's get started. Okay, so essentially for the objectives of today, in terms of radiology and pathology, we're going to be providing a broad understanding of what radiology and pathology entails, and some of the challenges that these two fields of medicine have. Essentially looking at some of the general utility of machine learning and artificial intelligence in these two fields, and addressing some of those challenges that radiologists and pathologists have, and kind of understanding a little bit on how to engage with the papers in the field as well. So with that, this is also kind of saying the same things. So we'll essentially tell you what radiology and pathology are. I'm pretty sure most of the people in the room know about this, but we'll do a recap. What are the challenges? Like I mentioned, some of the applications of AI that can alleviate some of those challenges. What is AI doing right now? Which is a lot, by the way, in radiology and pathology, if you don't know. Surprise, surprise. And we're going to talk about some of the advances that are up and coming in the field as well. Okay, so overview. So what do radiologists and pathologists do? So they kind of are similar, but a little different in that, now I understand why you say it's spotty. So they're a little bit similar, but also different in that they operate different sorts of imaging methods. So the radiologists operate radiation imaging equipment, not necessarily always radiation emitting ones. We'll go through them in just a bit. Pathologists operate microscopes. And essentially, radiologists look at the scans that are produced through those imaging equipment that they use, and pathologists look at the physical cells and tissues. It's some of the anatomical pathologists might like me saying this, but a lot of pathology is moving towards molecular pathology as well. So there's a lot of genetics and genomics, which you're going to hear next week, and I'm pretty excited about that. And Bahare is actually sitting at the back there, who's going to teach you about that. Okay, and so essentially they're both similar in the sense that they're both diagnostic arms of modern medicine. You probably know about radiological modalities, but again, just to do a recap, like I mentioned, I'm here for emotional support. I'm not telling you anything you don't know already. You probably know about magnetic resonance imaging. Gives you a tomographic image. Mostly we use it to show the brain here, but obviously you can do a lot of different things. It's pretty expensive though. So, and the wait times are really long for that. So we need something to do about that. Or we need to do something about that. Apparently I can't talk. X-ray is one of the major radiological modalities that's been used since the beginning of time. Or rather, I don't know, however many years ago when Röntgen did it. CT scans or computed tomography is another one. Positron emission tomography is another one. And ultrasound, which is actually up and coming. And there's a lot of point of care ultrasound that people are trying to use within primary care and in hospitals when they're doing triaging and all that stuff. It's a pretty neat tool to be used for that as well. In terms of subspecialties, radiology has a few subspecialties. So there's the diagnostic arm, which essentially uses to clarify certain diseases and conditions, and it can have anatomical subspecialties as well. Interventional radiology is actually a pretty cool subspecialty where you can kind of do some interventions and procedures on the patients. Like if you want to insert a chest tube or something based on an imaging modality, that's what they do. Radiation oncology is kind of in the middle of radiology and oncology, another cool subspecialty as well, which essentially uses radiation to treat cancer. And this is, like I mentioned, in between the two fields, and it's pretty cool subspecialty as well. Pathology. So there is the anatomical pathology, which is essentially looking at the body tissues. There's surgical pathology and cytopathology under it. And we have clinical pathology, where they look at essentially lab analysis of fluid and tissue. It can be chemical pathology, or hematology is in there as well. So looking at the blood smears and all that stuff. And like I mentioned, there's a lot of molecular pathology up and coming as well, just because we can get a lot of biomarkers and a lot of information from the essentially looking at the genetic variations between people. And it actually helps a lot with precision medicine as well. So essentially, TLDR version of this is the central role of both radiologists and pathologists is to provide those diagnostic information to help guide patient care and therapy within medicine. I guess I will hand it over to Michael to do the bulk of this now.
Hassan's being humble. Yeah, so thanks to Hassan for that great introduction to challenges of radiology and pathology. I see somebody here in the chat is asking about the link to the attendance form. We'll be sharing it again at the end of the lecture, so we'll have it up on that last slide for you. Can everyone still hear me okay like this? Okay, great. Yeah, so I'm going to take over for this part of the talk, talking a little bit sort of about challenges in radiology and pathology. We're going to look at some AI applications. Yeah, hopefully it'll be fun. So let's jump straight into it. What are some grand challenges in diagnostic medicine today? There's really sort of three main ones that we look at here. If we want to put them simply, the first one is that there's a lot more work. So imaging gets used more and more often, lab testing gets used more and more often. So there's just a huge amount of workload, and the sort of the rate at which we're producing these specialties simply isn't keeping up. So there's much more workload and not enough people to do it. The second is we want to strive for even better accuracy. So even though radiologists and pathologists are very good at their job, we want to eradicate any mistake in diagnosis. Oftentimes, this can be catastrophic for patients being put onto treatments that they don't need or they respond very poorly to. So we want to ensure we get the accuracy as high as possible. And then thirdly, we don't want to waste all of this data that we have, right? Like we have thousands upon thousands of patients going through our healthcare system every day. All of them are showing variations on the same diseases. And it's really a shame that all of this data is sort of not being utilized in a more effective way. There's only so much that an individual clinician can keep in their brain. Machines are able to do that far better than a human's able to do that. Okay, so let's discuss a couple of these a little more in depth. So number one, this increasing workload. Like, why is there more work, right? So there's been a study in the Netherlands. That's where the Zuiderland Medical Center is. Cool name there. But also studies in Canada and across the US and in Ontario show that there's pretty consistently a massive increase in the workload on pathologists and radiologists. And this is mostly because they've become integral parts of diagnoses for patients. So what that means is now when you go to the hospital, almost always, if you're presenting with something that's slightly anomalous, you're going to hear your physician in charge of you ask for you to go for blood tests, maybe an arterial blood gas. They're going to ask for you maybe to go for some smears. They're going to ask for you to do a CT or an MRI. And the reason they do this is because the technology is readily available and there's no point in sort of losing that assurance of confirming the diagnosis when you're able to do that very easily. So that was already leading to sort of this big increase. And then obviously the past couple of years, we got hit by something called COVID. And what that meant was a lot of people weren't actually able to go to the lab to get these scans done, right? You can't get an MRI scan done virtually. Nobody has an MRI machine that they wheel around. Real big, takes sort of a whole team of people to operate. So what happened is as soon as COVID let up, you now have this extreme backlog from several years of people trying to get their scans done all at once. And that obviously directly translates into extra workload for radiologists and pathologists who have, thousands of patients who've been waiting 3-4 years for their scans to get finished. Okay, the next one is maximizing efficacy. So like increasing accuracy. And I already told you guys, radiologists and pathologists generally are pretty good at their jobs. They do a lot of training, but they do run into certain issues. And the first question that I sort of want to ask you guys in the room and also to those on Zoom is what sorts of error do you think diagnosticians might make? So both pathologists and radiologists, what do you think are some sources of error for them? Anyone? There's some really simple ones, perhaps. Sure. Yeah. So if you're dealing with a sample that's just kind of ruined, right? Like somebody mislabeled it, or they didn't scan it in quite the right way, so you're unable to make a determination from it. We got some answers online. Yeah. So clerical errors we talked about. Fatigue errors. That's a huge one. When your workload goes up, you're really, really tired. You're much more likely to sort of just make mistakes because you're tired. So there's actually a bunch of classes of errors that radiologists and pathologists makes. I covered a couple of the more interesting ones here. So the over and the under read, this is pretty classic. The overread means that you identify a pathology that isn't there. You're so zealous and you think that this patient seems so sick that you identify something that's probably benign as something that's perhaps more serious than it is. Obviously not good if you send someone for chemo when they don't actually necessarily perhaps have a malignancy. The underread is just blatantly missing a pathology. It's actually much more common than you would think it is. A lot of pathologies have a way of blending into the background. And as you guys saw earlier on the scans that we showed, they're not exactly the best contrasted scans. So it's actually quite difficult to notice pathologies on them. The lack of knowledge error. You just haven't seen all the cases in the world. If somebody presents with something that you've never seen before, and the only time you've interacted with it was, 5 years ago during your residency training, you're likely not going to remember that pathology and you're going to misclassify it as something else. And then finally, faulty reasoning. And this is sort of a logical error on the part of the clinician. This means they saw the pathology there, but because of incorrect deductions from patient history or other information they have access to, they misdiagnose the pathology. So for example, you wouldn't expect certain diseases to occur in very young people. And so a diagnostician might make the incorrect call of saying they don't have a certain pathology because of their age. The next thing I want to talk about is there's also a lot of bias types that can occur within imaging, and this also contributes to a lot of error. I won't go too in depth into these. They're stereotyping, so you expect certain patients to have certain conditions, so it's very easy for you to diagnose them with that condition. There's availability bias, which means you're just more likely to diagnose conditions that you see more often. If everyone coming to you with a lung node, it has a benign lung nodule, you're going to expect most lung nodules to be benign, so you're less likely to find a malignancy. Regret. So a regret bias is essentially like you're worrying so much that you're going to underdiagnose somebody that it leads to you overdiagnosing. So the thought process is, well, I'd better not miss a malignancy. So I'd rather say benign tumors on the edge of malignancy are just malign and have them get treatment in case someone, dies from a mistake on the part of my diagnosis. And the last one is actually the most interesting one I find. It's called inattentional bias. I'm sure many of you guys have seen a YouTube video at some point in your lives where they ask you to count the number of times a basketball is passed or a red ball is bounced between a group of 3 to 4 people. And in the middle of it, they have somebody in a gorilla suit or a monkey suit of some sort run through the middle of the screen. And the whole trick is by the end of it, people will ask,
when did the gorilla man show up? And like most people in the room have no idea because they're so zeroed in on counting the ball that they don't notice what's happening around. They actually did a study with this for radiologists that had the exact same results. They gave radiologists a standard thoracic CT and they put a picture of a gorilla right in the middle of it. But they told them that they were looking for lung nodules, and 83% of radiologists were so focused on finding lung nodules that they missed the gorilla completely. They didn't notice anything was off about the imaging. So just to give you an idea, there is a pretty decent misdiagnostic rate. There's a lot of reasons for errors to occur, and that's why it's something that's important for us to sort of address and try to improve upon. Final issue that we run into in radiology is data utilization. So essentially, there's two aspects of this. The first one is that each modality of information contains so much more data in it than the human eye is able to discern. What this means is like when we take a picture, the human eye is really only able, even a trained human eye is really only able to discern differences between areas that are a certain degree apart, right? At some point, our eyes sort of lose the sensitivity to be able to tell whether or not two colors are different, whether or not a boundary necessarily exists. But this is something that's much easier for computers because they have the physical values, right? So maybe when a human thinks two gray zones are the same type of gray, the computer is actually able to say, actually, these things are a few RGB values apart, and that might be meaningful to diagnosis. The second thing about better data utilization is that we just have so much patient data through the sheer volume of people that our system sees that it's, like I mentioned before, it's impossible for one clinician to effectively make use of all of this information. But it'd be really helpful if we had access to every past case that we'd ever seen before. If we run into someone who's anomalous, it's likely that this similar anomaly has occurred within the system before. It's just that the clinician doesn't know when or who this occurred to. So we want to be able to make use of those past cases. All right, so we talked a little bit about sort of the big challenges, the grand challenges in radiology. Now we're going to move a little bit into how AI and ML can help us maybe address some of these issues and the cool ways that they're being used. So a couple of ways that AI is applied right now directly. And by directly, I mean, oh, we got some actually more nice errors in the chat. Thank you, guys. So in terms of direct applications, this means when the radiologist is looking at a scan in the process of making a diagnosis, how can AI be applied? Four big things that I want to talk about here. So number one is detection assistance. So this is really common in sort of cancer diagnosis. And the question is there a pathology even present? Like if I give you a scan and you look at it, can you actually tell me if there's a nodule there? Oftentimes it's a lot easier said than done, but computers, like I said before, are very good at identifying when something's asymmetrical, when something's out of place, due to the training that we're able to put these models through. The second thing is image classification. And this is very helpful, right? Because we want to be able to tell what sort of pathology it actually is. Blinked a little bit there. And why do we care about this? It's because certain phenotypes of certain malignancies in tumors, for instance, respond differently to different types of treatments. And what this means is, there might be a certain brain glioma that responds very well to one type of chemotherapy, but is completely resistant to the other type of chemotherapy. Our only current way of ensuring that, we have the correct type of glioma before we begin chemotherapy is by putting a patient that's probably already very sick from, the tumor in their head through an invasive biopsy. We have to get a sample, send it to the lab, and then have that result come back. If we were able to train a model that's able to effectively tell us what phenotype this tumor belongs to without needing to do an invasive biopsy, it really improves the prognostic sort of timeline for these patients and improves their care outcomes a lot. The next thing that we can use it for in direct applications is in lesion and tumor segmentation. This sort of is similar to detection assistance, but it's a little bit different. And this is, machines are able to tell us much more accurately than humans, certain models at least, where a tumor ends and where healthy tissue begins. Why is this important? It's important for two reasons. Number one, there's a lot of guidelines that sort of rely on the size of the tumor in order to judge what treatment should go ahead or not. And these guidelines tend to be very specific. So if a tumor is, larger than 2 centimeters, that's considered a more severe tumor. They should be elevated in treatment and chemo or surgery should be considered. If it's under 2 centimeters, it's considered more benign. It's considered sort of an observation style treatment. But oftentimes, if the tumor is relatively diffuse and the borders aren't very clear, it can be difficult for a diagnostician to make that call. And if a model is able to circle that tumor out for us nice and clear on the imaging, it can help them make that call. The second reason this is useful is in surgical planning. So surgeons sort of need to know where to start cutting and where to stop cutting. And oftentimes, once you actually get into a tumor removal per se, there's a lot of blood, there's a lot of complications. Orientation isn't always the easiest once you're actually in the human body, based on what you did planning before. So if we're able to give them a very clear segmented image of the tumor, it's going to lead to much better surgical outcomes as well, because they're able to know where they need to go in, where they need to cut, so they don't hit anything important, or they don't take out anything they don't necessarily have to. And then the final use that's very helpful in sort of direct applications for radiology is medical prognosis. So we can use the sickness timeline of previous patients to tell us how certain patients are likely to progress. This is really important because this tells us, do we need to urgently operate, or do we need to urgently send this person to chemo, or do we know from previous patients and their sickness experiences that this is likely something we have a much longer observation span on? Is this something that's more urgent? Is this something that's less urgent? And this really goes back to sort of what we talked about in terms of making full utilization of the long history of patient data that we have to improve outcomes for patients. Okay, next thing is in auxiliary applications. So this is stuff that's maybe not directly in the process of reading the image, not directly in the process of giving a diagnosis, but it's stuff that happens around diagnostic medicine that AI can help us in. So the first is feature mining. And this goes back to how I said in every image, in every slide, there's so many features that we just can't discern with our eyes as humans. And these are features that just aren't being used, right? They exist in the modality, but we just have no way to access them. And so if we're able to sort of train a model to identify which features are most useful or are most diagnostically relevant, then we can construct much better sort of decision matrices for whether or not a certain pathology, is dangerous or not. A really good example of this, if you guys want to check it out, a famous package developed by this team out at Harvard is called PyRadiomics. They created a Python package that extracts like all these strange, weird values from MRI images. So they'll do like, how many runs in a row of the same gray color are there within this tumor? And the computer can use that very effectively to sort of demarcate borders or decide whether or not a tumor might be more malignant or not. Whereas obviously for us, there's no way we're zooming in to each individual pixel and counting like, oh, this one has like the longest run of 7. It's just infeasible for us. Second thing that we can do is biobanking. So we can, take all the cases that we have, take all the information we have from these cases, and construct these massive data banks that can inform either future models, or we can just access through in an image search sort of style, right? Like the easiest way to use it would just be a very brute force of like, I don't know what this pathology is. Let me see if there's something that looks very similar to this in the past that's been validated and diagnosed. But obviously, the more higher level application of this would be the more data we collect, the better our models get in the future, because we have such a broad base of data to grow those models from. Third thing, workflow optimization. This is really important. So right now, we have such a big workflow backlog. There's sort of this question of who gets to go first, who gets to go second, which radiologist should see what imaging modality should be used. Like if you've been waiting 3 years since COVID, but you're just sort of non-emergent, you're likely going to keep waiting. But if we had a way to more effectively determine, maybe one radiologist is particularly speedy at like shoulder pathologies. They're just really into shoulders. They just want to look at shoulders all day long. Maybe there's a way for us to better schedule their workloads and better optimize the order in which they see images, so that we can actually improve sort of the speed and the efficiency at which our clinicians work. And that'd be really helpful, obviously, for clearing off a lot of that workload I mentioned earlier. And then the final thing that I want to talk about is logistical augmentation. So this is sort of directly how do we make the clinician's job easier? And this is, some of you guys have probably already seen this. If you've ever seen a modern radiologist or a pathologist do work, they have this little voice recorder thing, and they just sit by their desk, hunched over in front of their computer in a dark room, and they kind of mutter into it. If you didn't know what they were doing, it'd be kind of creepy. They're just like the whole day, just nobody knows what they're saying. What they're actually doing is it's something called Dragon Naturally Speaking, and it's actually been around for an extremely long time. It's a transcription service. It's an extremely well-made voice transcription service that utilizes AI and ML to transcribe what they're speaking into the patient note. And the reason this is so helpful is because there's so much volume and they need to note so many different features on each scan that doing something like typing is infeasible. They're all going to get carpal tunnel. Like none of them want to do it. So every pretty much radiologist and a lot of pathologists use Dragon Naturally Speaking. And this is just sort of one of the small ways in which You wouldn't think about it because it's not a direct application in terms of making the diagnosis, but it does meaningful good in terms of, increasing the workflow and helping ease the burden on our radiologists. Okay, cool. Before we hop into case studies, any questions about like any of the challenges or any of the sort of the interesting ways that we can apply AI in RAS and Path? All right, seems good. Okay, so let's hop into some case studies. So these are some selected results in lab medicine. And also here, we're gonna go into a little bit about, so oftentimes it can be daunting to jump into a machine learning paper because they like naming things weirdly. Like they like naming things after people, or just like, I don't know, CS is a bunch of nerds, so they got weird names like going around. So it can be really daunting jumping into a paper and trying to understand what exactly they're talking about. So I'm going to give firstly sort of a breakdown of how you might want to approach like an ML paper, because they're actually very easy to read, at least from the perspective of you trying to understand what they're doing and where you might build on this paper or what they managed to accomplish. So anatomy of a paper in ML, 4 really big parts. Number 1, the target problem. So what are they trying to solve, right? What's the issue that they're actually tackling? Number 2, data and pre-processing. This is really important for ML. So what's the data set that they use and how do they augment this data set? Why is this important? If they trained, a model on 10 MRI images and they're reporting an accuracy of 95%, it's very suspect, right? It's like, okay, did all 10 MRI images come from the same person? Probably. There's a ton of papers out there like that. So make sure you know where they're getting their data, how big their data set is, and what they did to it beforehand. Next, what model was used? So this is important because if you're looking to build on their research or to collaborate or to explore other avenues, you really need to know sort of how they approached it themselves, which model they use, so you know where to improve on or what new avenues to try. And then finally, of course, most importantly, like how did the model do? What was its accuracy? What was its sensitivity? What was its specificity? And oftentimes it's helpful to see if they have any suggestions for potential future directions. Ironically, not because you would likely take those future directions, they're probably already doing it, but you can read the future directions and know not to compete with them for those things because they're likely further along than you. Okay, so we'll hop into sort of 2 papers that I picked, one in radiology, one in pathology, and just quickly go through these 4 aspects to sort of demonstrate that like ML papers are really long and they like to say a lot of stuff, but at the root, it's really quite simple. Okay, so the first one is a paper in radiology that we got from the IEEE. They took a deep learning approach for a classification task, and the pathology that they're targeting is a brain tumor. So what was their target? Sort of what was the issue they're trying to solve? The issue they're trying to solve is the classification of a key chemotherapy contraindication. So like I mentioned before, there are certain tumors that react very well to certain types of chemo and others don't. So what they were trying to do is see if they could classify based on images which type of tumor this was, so it could inform treatment going forward. What data did they use? They used the RSNA McKay augmented standardized resized data set. It sounds really scary. Like Isan said, we just really like shortening stuff to scare people off. Not confusing at all. So what's the RSNA? It's a Radiological Society of North America. A bunch of radiologists get together, I don't know, mutter into their little dictaphones. McKay is just this massive data set that they provide as part of a brain tumor AI challenge. There's a lot of these organizations out in the ML space where they just collect databases and they provide these databases to sort of academic centers, to researchers, so that they have a good base of data to build these models off of. McKay and RSNA are 2 of the most common people you'll see data coming from because they provide a huge amount of data and it's all validated for use. So essentially, it's very easy to access and you've got a ton of data to work off of. Augmented, standardized, resized, what does that mean? Augmentation just means they essentially took some of these images and they did weird transformations to them because they said, we actually don't even have enough data despite the large data set. We want more data. So they would take an image, they might like twist it a little bit, they'll take another image, they'll invert it. They're trying to change the image in a way so that their model has more data to be trained on. Standardized, it just means they went through, they made sure all the data, all the images were like same size, they used the same range of RGB values. There wasn't any one where like it was missing a slice or missing a piece. They took out all the ones that sort of didn't fit with whatever standards they set. And then resize just means they resized it to fit whatever model they were using. You'll see this a lot. Certain models just prefer working with inputs of a certain size, and sometimes you just need to scale it up or scale it down. Okay, what model did they use? They used a pre-trained efficient netbow in TensorFlow. If you run into stuff like this, my number one opinion is just like Google it and someone will have a nice, simple explanation of what it is. And oftentimes with a lot of these exploratory papers, these will be open source, publicly available models. So in this case, what this is just a convolutional neural net. I think we did touch on it a little bit earlier in the course. It's a deep learning network with a certain design. It's named after like the creator who came up with a particular algorithm, not particularly important to know. Good to know that it's in TensorFlow just because TensorFlow is publicly available. So you can likely go into TensorFlow and use the same network. They used a transfer learning. They use transfer learning with an atom optimizer. Again, more machine learning talk. Stack Overflow is going to be your best friend here. If they use TensorFlow for the first part, they likely use TensorFlow for the second part. And these types of papers we really like because it means that we're able to take the same data that they use, go into TensorFlow ourselves, set up the same parameters, and see if we're able to replicate the results. If we are, they probably did a good job. Most of the time, you're not going to be able to replicate the results, which then you would need to go back to the paper, see if you got parameters wrong, see if you pre-processed the data wrong. And more commonly, you need to contact them and be like, hey, the data is not matching up. And they'll probably ignore you. Sometimes they'll respond and be like, I don't know what you're doing wrong. This is just sort of the state of where ML in healthcare is for a lot of places. And then finally, what was their result? So the result here was a max accuracy of 72% on a specific type of MRI image. It's a T1 weighted image. It's just a specific type of MRI modality. But what I wanted to ask you guys is, do you guys think this max accuracy is good? Like generally, a general sense, 72%? Are we happy with that? Depends on how you use it. That is, yeah, that's a good point. So it would really depend. Are you using this as sort of a diagnostic assistance tool? So are you using it as like a suggestion, or are you using this as something definitive? If it's something definitive, probably 72% is not a risk we're willing to take. You know, wrongly sending 28% of patients for chemo they don't need is not going to fly. But how do you think this might inform our next steps regarding this paper? So after we read this paper, what's something that might be interesting to look into? Anyone online? Personally, as a researcher that doesn't have the resources to be able to compete with some of the models that are hitting the 97, 98% accuracies, when I see someone with a paper of an accuracy of 72%, my eyes light up because it means there's room for me to wiggle in there and maybe make some improvements to that model, right? 72% is, it's like better than a coin flip, but it's at a point where like we could probably improve on it without the need for insane hardware, without the need for extremely fine-tuned networks. So that's always something to keep an eye out for. Usually on these ones, if the accuracy is relatively low, it tends to be an exploratory paper, and there tends to be some room for, like, you know, you to wiggle your way in there and maybe make a result for yourself. Okay, the next paper we'll look at, we'll zoom through this one, is a paper in pathology. So, like for example, yes, yeah, exactly. It depends exactly what we would be focusing on, what the task would be for. Okay, paper in pathology. Similar to before, IEEE, the approach was a neural net and a deep neural net. The task was regression, and the pathology was dysphonia. So what they were trying to do is they were trying to judge the severity of a voice pathology using a voice sample. This became much more relevant during COVID when they weren't actually able to see the patients, but obviously speech therapists and speech language pathologists could ask patients to send recordings of their voice. And this could inform them whether or not sort of there was a growth there maybe, whether or not there was something wrong with one of their nerves in terms of controlling their voice. So the data that they use is a natively collected data set of 128 MFCC extracted, more scary words. But the most important thing to notice here is that it's natively collected. Why is this an issue? Probably means that their data set isn't publicly available online. And secondly, means even if we ask them for the data set, there's likely no way they're going to be able to release their data to us because of patient privacy concerns. They've likely only received permission, you know, to use the data within their health network, within their research network. So it's really important to keep stuff like this in mind so that you can avoid sort of jumping into a project, getting all the bases set up, and then realizing you don't have access to the data you would need to validate their paper. Did you have a question? Exactly. Yeah, so if you have no way to see the data, you have no way to know if they purposely select, you know, they selected 127 people with a voice pathology and one without. And their paper is like, oh, I'm so good at identifying voice pathologies because it just says yes to everyone. And they're like, wow, what great accuracy. Exactly. What's MFCC? Essentially, it's a measure of derived sound and timbre. Again, if you see something that's like an abbreviation of something, throw it into Google. Someone will have a beautiful written explanation for you. They'll explain how you use it. Stack Overflow is a wonderful place. What model did they use? They used an out-of-the-box NN and DNN models with ADAM optimization. Again, ADAM is just an optimizer. Out of the box is really important. What does that mean? Similar to TensorFlow, it means it's an open source, publicly available model that we're likely able to access. But it's more important when we take it in the context of their results. Because for their results, they say that they achieved a max accuracy of 92.3% with an out-of-the-box deep neural net. Do we have any opinions about that result with sort of what their paper is reporting in terms of what their data is or what their model is? What would you guys think if you read that paper? Is this like is this a model you'd be jumping on to adopt? That's pretty good accuracy, like 93%. Exactly, right? So they're using something that's out of the box, it's publicly available. Someone made it for a task that's just very general. They took it to this extremely specific task of judging a voice pathology. They used a natively collected data set, and now they're reporting an accuracy of upwards of 90%. This would probably be something that would be a good idea for a validation study, right? You might want to see, they likely did something during the data pre-processing is what I'm guessing that led to them to be able to get to this high accuracy, just because it just doesn't jive that you would be able to do such a specific task with such a generalized model and achieve results as good as this, right? This is, if this was true, it'd be, I don't know, it'd be amazing. A lot of hospitals would probably be using this. All right, so finally, we're going to cover quickly what's next in radiology. So there's three big main areas of improvement that we want to focus on. Number one, improve data utilization. So even though we're already looking to utilize data, we want to do that even more. We want more data sharing. We probably want better anonymization protocols so that it's easier for healthcare data to actually be shared across sites. One of the big issues right now is each site can have their own big database, but they can't share it with other networks because of patient anonymization concerns. We really want to utilize sort of the full volume across all the healthcare sites that we see. Number two, we got to put these models into direct clinical practice. There's a ton of theory going on right now. There's a bunch of papers like the voice pathology one that are saying, you know, they're hitting 93% accuracy. But until we get them into clinical practice and have doctors and other healthcare professionals validating their usefulness, adoption is always going to lag behind because patients are never going to want to use something that the doctor seems a bit loath to use, right? Finally, directed model development. I mentioned this a little bit in that last paper. We want to start developing models specifically for the modalities in medicine. Right now, a lot of these papers are just adopting general stuff made for like classifying pictures of cats. And they're like, hey, what if we threw some MRI images at it? If we were to design a model specifically for the classification of MRI images, it likely means that we'd be able to tune the model much better to understand those MRI images and get way better results. But obviously that sort of hinges on more widespread adoption and better access to data. All righty, that brings us to the end of RADS and Path. I know that was quite a bit. If you guys have any questions, let me know. I also know we're sort of rushing against the clock, but we'll hop into cardio. Cardio is a bit shorter than this. So hopefully we'll be able to get through it. Do you want me to I'll just go through that. Yeah. Originally, Hassan was going to come up and introduce cardio as well. But we'll live on the edge. If it loads for me here, and there it is. Okay, so new presentation, new template, red this time, not blue. So AI in cardiology, let's jump into it really quickly. Lecture objectives, pretty similar to last time. Want to provide you guys a general understanding of what cardiology is and some pertinent modern challenges in the field of cardiology, and then review some examples of current machine learning-based approaches to solving some of these problems in cardiology. Okay, the contents are very similar, except we cut out the last two bits. So intro to cardio, some challenges in the cardio, and then what are some solutions that are being developed in AI right now. So let's get into the introduction first. Cardiology, again, probably you guys know what cardiology is. It's a medical field concerned with the maintenance, understanding, and management of pathologies and regular functions of the heart and the cardiovascular system. So your veins, your arteries, all the stuff that pumps blood around your bodies. There's a bunch of subspecialties in cardiology. We're not going to get into them. The gist is they deal with heart stuff. And the heart stuff is important because, as you know, towards the end of your life or towards the tail end of any pathology, it tends to be, your heart that gives out first. Sort of the thing that keeps us alive. Heart or brain, one of those guys goes, and the other one follows. So what are the three main components of cardiac care? There's three main components of cardiac care that we care about. It's a little bit different than RAS and Path because cardiology is a clinical practice. So they don't only get called in for sort of consults on like, do you think this is a tumor? They do deal with the patient more longitudinally throughout their sickness experience. So the first thing is prevention, right? Every cardiologist's dream would be to catch every person that's at risk of developing a heart pathology and just like get them to improve their lifestyle so they lower their chances as much as possible from developing that pathology in the first place. Always better to just not get it than to have to treat it. But the second thing is inevitably when people do develop heart pathologies, there's things like genetics. There's obviously just like you can never get the chance to zero as we age. Environmental factors are going to lead to heart pathologies. What do we do at the point of care and how do we maximize sort of the trustworthiness and reliableness of our current treatment protocols? And then thirdly, longitudinal care. So the heart does a poor job of healing. So once you sort of have something catastrophic happen with the heart, we got to treat that patient longitudinally. We got to make sure they're okay moving forward. And we have to plan for future issues with their heart as well. So those are the three main components of cardiology that we're worried about. And then we're going to talk a little bit about issues in each. So challenges in prevention. The general idea in prevention is that we know that there are certain characteristics or patient habits that are correlated to higher cardiovascular risk, right? Like if you have a lot of atherosclerotic plaque, if you have high cholesterol, we know that just puts you at a higher risk of clotting. It's a correlation that we've observed. The only issue is it's not always consistently clear on patient presentation, right? And a really good example of this is smoking. There's certain patients that, have like an 80-pack year smoking history, and they're chipper. They're fine. They like don't present with a cough. They're running around okay. And then there are other people who smoke for 3 months and they present with something extremely severe like lung cancer. So the issue is there's no sort of consistent way for us to be able to classify these patients. A major challenge then is providing sort of an effective and reliable method to stratify patient risk and know which types of early stage intervention works best for each type of patient. Okay, challenges at point of care. Three main challenges at the point of care. So number one, accuracy, sort of similar to radiology. Like how do we make decisions in acute situations that are accurate and actually will inform our treatment moving forward? Secondly, efficiency. Like I mentioned before, everything in internal kind of drains down to cardio. Like at some point, once you get sick enough, it's your heart that's giving out. So how do we increase the efficiency of cardiologists working in order to ensure that we're able to see as many patients as we can, but still maintaining a standard of care for those patients? And then thirdly, efficacy. How do we ensure that the treatments we give actually address the presenting pathology and will improve the patient healthcare outcomes, not only sort of in the acute setting, but also longitudinally moving forward? Finally, challenges in longitudinal care, two big ones that we're worried about. One is trajectory modeling. Like is there a way for us to know where this patient is likely to end up in 5 years? Couple of reasons this is useful, right? Number one, it informs how stringent our interventions are going to be. Like if we know that someone's going to deteriorate very rapidly, we know to intervene much more aggressively. Secondly, it's useful to let the patient know what their trajectory is. So often it can be hard to convince patients in the early stages of sort of these risk factors for cardiovascular risk to act. But if we're able to stratify them effectively, it might be easier to get them to be willing to participate in interventions or, like consider these interventions. The second thing is in precision medicine, which Hassan mentioned a little bit earlier. And what precision medicine is, how do we tailor treatment and long-term management based on the specific genetic profile of patients? We know that certain patients, respond to certain drugs better. We know that certain patients are able to do things like lower their cholesterol easier, and other patients have a much harder time doing things like bringing their HDLs and their LDLs down. So is there a way for us to use the genetic profile of these patients to know which interventions are most successful so that when the patient participates in these interventions, they're more likely to adopt them in the long term because they see the short-term effects of these interventions taking place? All right, so what are some current AI solutions that are being used to address these goals? The first thing that we want to talk about is this is a paper. It's a sort of a systemic review of what's being done in the space right now. And what it shows is that the number of papers in cardiac AI has been increasing rapidly during the last few years. So originally, radiology and pathology were what machine learning engineers immediately took to. They saw the modality. They're like, these are images, right? We know how to work with images. Let's do image work. But cardiology has become sort of the next frontier that machine learning engineers are targeting. And the reason for that is because a lot of cardiology is also algorithmic. If you're looking at ECGs, if you're looking at sort of the results from their blood testing, a lot of it is just calculations into a risk stratifier and figuring out where that puts your patient. Next, so yeah, this is sort of a investigation into what areas these papers are being done in and what areas of research are being done in. Perhaps not surprisingly, AI is being used a lot in like prediction, diagnosis, and classification. But interestingly, as we can see, there's actually a lot of other smaller subcategories that there's ML development being put into as well. And really what that tells us is that the ways in which people are thinking to apply ML and AI within all of these fields is really expansive. And oftentimes it's not always the most clearly evident way to apply ML that gives the best results. Finally, this is just a list of some cool FDA-approved cardio-related ML products. I'm sure you guys have heard of a lot of these. Apple is very giddy about their Apple Watch being able to take ECGs and give you sort of heart rate readings. We'll actually talk about that a little later. But yeah, there's significant commercial development in this area, more so than radiology and pathology, because cardiology is much easier to pitch to the consumer. Like, hey, you got a bad heart? I got a bracelet you can wear that'll tell you when your heart's getting bad. Much more difficult to convince a patient about the benefits of, an MRI classifier, mostly because they don't get to see their own MRIs. They can't take their own MRIs. Okay, so let's take a look at quickly at 4 ML solutions. We're going to take a look at AFib detection. So atrial fibrillation is just it's when your heart loses rhythm in a certain way. We're going to look at ECG analysis. So ECG, the ever famous ECG, your little green blip on the screen that everyone's watching, and then a flat line. Oh, no, the patient's dead. We're going to look at asymptomatic diagnostics. So how do we tell when somebody who's not presenting with any signs of cardiovascular failure is at high risk of cardiovascular failure? And then finally, readmission prediction. So how do we know how patients are going to perform when they leave the hospital and leave our imminent care? Like, are they going to be back in 3 days? Because if they are, we should probably just give them prophylactic or treat them for whatever they're coming back for before they leave. Now, quickly, an exercise for fun. What's the fuss about ECGs? So this is a standard ECG. I don't know if anyone here is very experienced at reading ECGs, but this is what a regular one looks at. Look at it, appreciate it. You got little blips. Some of them go up, some of them go down. Now I got some questions for you guys. So on this next one, I want you to tell me if you think this ECG is normal or not. Like if I threw you into an emergency room and someone asked you, is this guy, severely sick? What would you tell me? So this ECG, you guys think it's normal, pathologic? Oh, somebody in the chat does ECGs. Yeah, this one's not good. There's no sort of structure, just waving all over the place. And as chat correctly says, this is ventricular tachycardia. What this means is the bottom of your heart, sort of the big pumps of your heart, are just going crazy. They don't know what they're doing. Not good, obviously. They're sort of what's responsible for getting blood around to the rest of the body. I'm going to show you guys another one. Same exercise, normal or pathologic. Do we think this guy is doing well? Yeah, so asystole is correct. Yeah. So, for this patient, they're either flatline and dead, or we didn't attach the leads correctly, and the patient is alive and well, and we're measuring like the frame of their bed or something like that. So those two were pretty easy. One looked like a sine wave, the other one's a flat line. Anyone can be like, probably not doing too hot. The issue is when we come to stuff like this. Like, is that pathologic? Kind of hard to tell. Even for an experienced cardiologist, it might be difficult to tell. There are certain features that we know to look for, but similar to radiology, like the human eye can only do so much. So there are general guidelines. Let's say if an interval is wider than however many blocks on the square, but what happens if it's like right on the border? We don't really know what to do. So the reason ECGs are such a good modality for AI and ML is because of the fact that, again, it's very much image-like in sort of the approach. You're able to take very classical features from this. You're able to extract them. The computer can deal with them very specifically and in a very minute scale that humans are unable to do, and likely provide better diagnostic outcomes than clinicians are able to. So on that note, the two big sort of ECG-related applications for AI, as I mentioned before, are ECG analysis and AFib monitoring. So ECG analysis, why is that important? As you guys just saw in that last one, some ECGs are just awful to interpret, right? And in acute situations, sometimes you need to know very quickly. And it's a key diagnostic tool that's used not just in cardiology, but for like every specialty, right? You show up to the ER, the first thing they do is they get ECG leads on you, because the most important thing for them to know is whether or not your heart's still going. You can cure whatever other disease they have, but if their heart stops, it's kind of over for the patient. That was a little morbid. And the issue is it's often really minute details that separate a pathological and a normal ECG. And what ML models are really good at doing is picking up on those minute details much better than a clinician can, especially when that clinician is in an acute situation under a lot of stress and doesn't necessarily have the time to whip out their trusty ruler and be like, aha, this wave is slightly too high. The second thing that's useful is an AFib monitoring. So atrial fibrillation, ventricular tachycardia, like I mentioned before, is the big pumps of your heart sort of going crazy. AFib is the little pumps of your heart going crazy. So the big pumps need to be filled by the little pumps before they pump out to the body. AFib is when the little pumps are just, they don't know what they're doing, doesn't fill the bottom pumps. Similar result. The issue is AFib is actually one of the most common arrhythmias in the clinical population. And it's very difficult to notice when it first starts occurring. And the reason for that is because it tends to come and go in phases. So you'll have a short episode of AFib where you might feel a little breathless, but then your heart is able to kind of wrest back control of your atria, and you'll feel normal again. A lot of people will attribute it to like, oh, I must have just like walked a little too fast, so I'm kind of breathless, I'm out of breath. It's very easy to dismiss. And the issue with AFib and cardiological monitoring is because it phases in and out and ECGs are snapshots in time, it's really easy for clinicians to miss too. So even if you come to a clinic and you tell me, I've been having these bouts of tiredness, I'm kind of randomly getting short of breath. An ECG, there's no way to guarantee it's going to catch your AFib in action, especially if you have irregular AFibs. So a clinician might look at the ECG and go, no, you're perfectly healthy. You're probably just overexerting yourself. So what's the solution to this? Well, ML model integration in things like the Apple Watch and other wearable tech allows consistent tracking across the day, right? So if you have your Apple Watch on your wrist and it notices an AFib starts occurring, it's able to immediately start recording your ECG, record how many times a day it's happening, and also provide those ECGs to clinicians. Why is this helpful? So the accuracy on Apple's ECGs are probably not clinician grade, but it's helpful because A, it proves the likely existence of AFib, so your clinician can do something about it. And it also gives them some idea of when this AFib is likely to occur. So they might be able to get it more accurately on lab testing by emulating the conditions. So like, if you're every time you go out for a run, your Apple Watch is like, you're getting into AFib, they can ask you to run first and then take a scan. And if they're able to see that AFib clinically, then they can start treatment much sooner rather than later and improve your outcomes by a lot. Okay, next, surprise, surprise, yeah. So like I mentioned earlier, cardiologists already love algorithms. And the reason for that is, like I said, a lot of cardiovascular risk just doesn't present until it's really late. Like our heart is really good at adapting to clots and blockages. So if you have a clot in your heart from something like atherosclerosis, so essentially a cholesterol plaque in your heart, unless it occludes over 70% of an artery, you're not really going to notice any meaningful symptoms in your heart. You're not going to get ischemic symptoms because your heart's really good at adapting and trying to keep you alive. It's sort of, like its main job. So cardiologists like to use algorithms because they need a way to sort of classify people who don't seem like they have cardiovascular pathology, but look like they might have risk factors. And one of the most popular ones is called the Framingham Risk Score. Very easy to use. You just sort of ask your patient all these questions, you plop them in and it'll tell you, it's like, this guy's gonna get heart disease soon. You should tell him to stop smoking. And you can go and hopefully tell them to stop smoking. But the reason algorithms are important is because algorithms are what ML models and AI models love, right? Like if you feed them an algorithm and give them a ton of data, that's when they really have a field day and they're able to outperform humans by a lot, especially because, like I mentioned before, they can access a lot of data that clinicians might not be able to access, both in terms of just like the volume of data they can access and also what they can glean from that data. So an application of AI and ML for cardiology is asymptomatic prediction. So like we saw with AFib, lots of cardiac pathologies sort of remain hidden until they reach a critical point. So what we want then is sort of a contemporary way in order to judge whether or not patients are at risk of developing these pathologies before they actually start presenting, because often by then it's, like I said, 70% blockage, 80% blockage. The treatment options aren't fantastic. You're either going to give them a fibrinolytic and they're just going to like bleed everywhere, or they have to go in for surgery, which obviously there's a ton of complications associated with it. So some current work by some contemporary researchers by Allah has showed really promising signs of improved cardiovascular risk prediction using even just out of the box models. So even by just using the basic models that come with things like scikit-learn or TensorFlow, they were able to beat out some of the accuracy and the prediction ability of the Framingham score. What this means is even with these basic models, we might be able to replace sort of our current options. Obviously with the Framingham, it's just from a general study like in the 1960s, I think 1970s, where they did on one town in the United States. So it's not going to be very good at making these classifications. So if we're able to replace that with something that's a machine learning model using making use of all the patient data that we've collected, it's likely to lead to much better outcomes in us identifying high-risk patients. And there's a lot of work being done in that area now. And then the final thing that we want to use ML for in cardiology is post-treatment outcomes. So this is what I was talking about in terms of longitudinal tracking. Because the heart's really poor from recovering from catastrophic events. Cardiac tissue doesn't really come back. So once you have sort of ischemia in your heart and you lose a chunk of the muscle, it's just gone and your heart is just like permanently sort of weak, which obviously means you're at higher risk of developing new heart issues down the road because your heart isn't functioning at 100%. So what we want then is we want to be able to recognize during treatment which patients have the highest risk of readmissions so that we can just design an outpatient care plan for them that tries to minimize their risk of readmission. So like I mentioned before, if we know that this person is at risk of like readmission within 5 days because they're going to go into heart failure from the fact that their heart just got, destroyed by an ischemia, then we might just want to keep them in the hospital for that additional 5 days for monitoring. We might want to give them a different pharmaceutical plan or install a pacemaker in these patients preemptively because we know that they're much more likely to require one in the future. And instead of bringing them back into the hospital, messing up the workflow, obviously reducing sort of quality of life for the patient because they thought they were out of the hospital and now they're being dragged back in, we can just do that all in one fell swoop. Additionally, it's really helpful for patients to know sort of where they're headed, right? A big part of the scary thing for patients is you have a heart attack and the doctor can't really tell you what's going to happen, right? It's like, well, we don't really know if you're the type to have a heart attack again in a year, or you're the one who's going to have one now and your next one will be like 30 years down the road. So it's much more helpful for patients to also know what their likely trajectory is going to be. And the paper quoted here by Mortaza it's essentially a preliminary exploration of ML methods, which showed that there are high fidelity outcomes in predicting readmission risk for patients 30 days post-discharge. So essentially, they took a cohort of patients, they used an ML model to predict where they would be 30 days post-discharge, sort of what their trajectory would be, and then they compared it to what these patients actually ended up doing, which ones got readmitted, which ones were fine after the 30 days, and it showed like decent accuracy. It showed that ML methods were outperforming traditional logistic regression, so just basic graphing, and it shows that this is probably a viable methodology for us to move forward as well in terms of replacing the algorithms that we currently use in this space. I think that brings us close to the end. I'll just quickly go through this. I know we're a minute over time. Thanks for staying, everybody. This is just really quickly sort of a role for non-ML experts in machine learning for cardiology, but also broadly for healthcare. So oftentimes it can feel like unless you're sort of the one developing the models, it's very difficult to get involved. But that's actually not true at all. So just a couple of the highlights sort of from this potential list. There's obviously a lot of stuff that's not on this list, like beta testing in clinics, right? So we need people within clinics or within healthcare settings to actually test out these algorithms and report their efficacy back to us. Being a champion for new ML solutions at their home institutions. So this means advocating for the adoption of these ML models, because oftentimes a lot of healthcare institutions tend to be very slow and resistant towards the adoption of this sort of technology. Being a patient advocate for the adoption of new technologies, or even being a patient educator about new technologies, right? In order for ML to sort of become an integral part of medical treatment in the future, we need patients to buy in. It's never going to get anywhere if no patients are willing or feel safe using the model. And a lot of that we feel like comes from patients understanding how the model works, patients understanding where the accuracy comes from. And then finally, you can create a training course like AIMS to help try to inform more people about ML in medicine and sort of what that entails in order to, again, improve sort of acceptance of it and understanding of ML, so that hopefully more and more people are willing to give these models a chance, because they're doing some pretty cool things, and hopefully they're able to really help improve patient outcomes moving forward. Yeah, that brings us to the end. We managed to fit everything in. Thanks everyone for staying. We can take some quick questions if anyone has any. You can peek on the Zoom. That's horrifying to know after 70%. Yeah, you could have an atherosclerotic plaque in your heart. No, probably not. But I think all men over 40 have atherosclerosis somewhere in their body. So that's going to happen. Can't really avoid it. Just hope it's not too much. Hope it's not in the wrong place. Hopefully these models are better by then. All right. Thank you, guys.